right, just working on getting a PowerPoint open. All right, so next up, I'd like to introduce Dr. Jared Klein from the University of Washington Harborview Medical Center. Dr. Klein is the medical director of the Pioneer Square Clinic Downtown Programs at Harborview and an attending physician in the Adult Medicine Clinic. He's an associate professor of general internal medicine for the University of Washington School of Medicine. Dr. Klein enjoys working with patients to help them understand and improve their health. He feels his role is to guide his patients through the complexities of the healthcare system. Dr. Klein's clinic and research interests include treatment of substance use disorders, care of persons experiencing homelessness, management of chronic diseases, and disease prevention. Please welcome Dr. Klein.
Thanks so much for the introduction, and nice to see everyone today. As Dr. Hayes said, I'm Jared Klein. I'm an internal medicine and addiction medicine doc. I work at Harborview, and a lot of my practice is primary care. I see folks doing primary care, doing walk-in care in some of Harborview's healthcare for the homeless settings, and then about 5 or 6 weeks of the year, I work in our inpatient addiction consult service at the hospital, helping take care of hospitalized patients with substance use disorders. And that's, I think, why I was invited to talk about some opioid updates. And really, I focused most of this talk around kind of new and emerging trends, both for the inpatient and the outpatient setting that have come about in the last year or couple years. So yeah, I'll go through the outline here, which is pretty high level. I wanted to just briefly provide a little context for some of the talk, and then really focusing on just a handful of tips or take-home points for both the inpatient setting and the outpatient setting. So hopefully folks that work in one setting or the other or both have something that they can potentially put into practice. And then the last topic, regulatory changes, sounds so boring, but there's just been a huge amount of change in this area over the last year or two, kind of emerging from the pandemic, so to speak. And so wanted to make sure everyone was aware of some of those updates. I don't have any financial disclosures. I will discuss some off-label use of medications, and I'll try to highlight that as we go through today. So first, a little context, and the pun is, I guess, intended here. Fentanyl has been a game changer, essentially. I think most folks here are aware that over the past several years, the drug supply locally has changed to an incredible degree. We went pretty rapidly from seeing mostly heroin and prescription opioids to almost entirely fentanyl. Now, if we have somebody who is using something other than fentanyl, it's a little bit kind of remarkable about kind of how do you access that? That's interesting. So I think you can't overstate the impact of this. The potency of it, which is implied from this photograph from the DEA, that a dose of just 1 or 2 milligrams is potentially lethal, especially to somebody who's opioid naive. And that potency has multiple effects. For one, there's the increased risk of overdose with it, but also really the degree of physiologic dependence that we're seeing for folks that are using fentanyl is just much, much different than in prior eras when folks were using more prescription opioids or heroin. That potency and also the very relatively short duration of action also impacts the kind of reinforcing effect of fentanyl. So, you rapidly get a euphoric effect from using fentanyl, and then that also rapidly goes away. And that cycle is very reinforcing kind of behaviorally for folks. The other thing that goes along with the potency is the lipophilicity of fentanyl. So when folks, especially when you smoke fentanyl, it rapidly crosses the blood-brain barrier and you get that euphoric effect very quickly. But it also sticks around. You can get essentially a depot in adipose tissue, which means that even though it's a short duration of action, when people are using chronically, they actually can have fentanyl in their system after their last episode of use for days to weeks even, potentially. And that really complicates things when we think about treatment and how to help people get onto treatment. So, I think all this context hopefully helps you understand why not only is it more challenging, but it's also incredibly, it makes it much more important to be talking to people about treatment, to be working and trying novel approaches to getting people on treatment and engaged in treatment. All right, so with that context, let's talk a little bit about the inpatient treatment of opioid use disorder. I'm going to start with a case just to provide a little bit of kind of context or help you kind of enter into this the space where we're thinking about how we might do some of these, use some of these strategies. So you're admitting a patient for low extremity cellulitis. They use fentanyl via inhalation multiple times a day. They're prescribed or they're ordered for oxycodone 15 milligrams every 4 hours. So you're trying to be pretty aggressive with pain control and withdrawal treatment. But unfortunately, they're continuing to have objective signs of opioid withdrawal. So they're a little bit diaphoretic, their nose is a little runny, they're feeling pretty restless, and their pain is poorly controlled. So how are you going to manage their withdrawal symptoms in this situation? So I'm going to talk about a couple different strategies, 2 different strategies with 2 different medications. So let's start with buprenorphine, obviously partial opioid agonist. And I'm not going to go into all the pharmacology of that. I'm hoping folks are pretty familiar with buprenorphine. But historically, what we've done is basically treated people by waiting a period of time and then starting buprenorphine once withdrawal starts. The challenge with that is that long duration, how long fentanyl kind of sticks around in the body for folks that have been using chronically. And if you were to just start buprenorphine in that situation, the risk is that you could precipitate withdrawal, of course. And so I have a graphic here, and hopefully this analogy, which is from a colleague in Yale who was actually a resident at UW previously. He published this paper a couple years ago now in Journal of Addiction Medicine that I think is a helpful analogy as we think about different strategies for starting buprenorphine. So the strategy we're going to eventually get to is this overlapping buprenorphine start. Other phrases people are using for it is a low dose initiation or micro dosing. We're kind of trying to move away from that language a little bit because dosing is a little bit arbitrary. Like the dose is, one person's low dose might not be another person's low dose. And really it doesn't tell you anything to the actual mechanics of how you're doing this. An overlapping start is, I think, pretty clear. It means that you're continuing full opioid agonists and overlapping with buprenorphine. The other reason is we're trying to move away from that microdosing thing. There's a lot of confusion around microdosing and psychedelics and all this stuff, and it just gets a little bit complicated, I think. So, all right, let's get to the analogy. All right, so let's envision that you're in this car and you're going on the freeway, you're going 60 or 70 miles an hour. That's the person who's using opioids or using fentanyl regularly. Their opioid receptors are like in overdrive. They're full steam. If you were to just give that person buprenorphine, it's like slamming on the brakes. You're going all of a sudden from 70 miles an hour to 20 or 30 miles an hour. It feels terrible. We call that precipitated withdrawal. So A here is precipitated withdrawal. All right, B is the traditional, like a kind of what some people call traditional, or like what we previously would do, like a withdrawal first start, where there's a period of where you're not using opioids. This graphic says hours to days. It's kind of arbitrary how long it is, but essentially you lay off the accelerator and you're letting the car slow down, and then you're adding the buprenorphine back. And the car is actually speeding up a little bit at that point. So you've slowed all the way down to 10 miles an hour and you're going up to 30 at that point. The challenge with fentanyl is it doesn't take hours to days. This period can take days to weeks for the car to slow down. And so that's why this kind of more traditional or withdrawal first start is very challenging, and why particularly in the hospital we're thinking about an overlapping buprenorphine start. So this is line C here, where the car is at 60, 70 miles an hour. And what we're doing is we're giving teeny tiny doses of buprenorphine, which is essentially like tapping the brake instead of slamming on the brake. So we're just tapping the brake. So we're going 60, 55, 50, 45, and doing this over the course of, it's kind of arbitrary. They show 5 days here. You can do it over all sorts of different time frames, and we'll talk about that. But you're gradually introducing that medicine so that any kind of withdrawal that folks are having is very, very gradual, and then you're finally on the full dose after a period of time. I alluded to the time frame, and the time frame is, like I said, arbitrary. So buprenorphine, when given sublingually, has a peak effect, we think, within an hour or so, maybe 30 minutes for some people, maybe 90 minutes for some people. But essentially, if you give a dose and you watch them for an hour or two, and they're not having precipitated withdrawal, then you could probably give another dose. So some people will do this as frequently as every 3 or 4 hours to give these doses. Sometimes we do it longer. Sometimes we stretch it out several days between doses if people aren't tolerating it well. The next slide will show you a sample protocol, and we could talk more about that. But the time frame is a little bit arbitrary. The important thing to realize that for hospitalized patients, we generally would continue short-acting opioids and/or methadone throughout this entire time frame. The goal is not to necessarily discontinue those right away. The goal is to safely get someone on a medication while they're on their other short-acting opioids or methadone or both. This is an example, protocol from that same study from a couple years ago. There are lots of ways to do this. This is something pretty similar to what we generally use at Harborview. The main thing is that these initial doses, as you can see in the top line, let me see if this works. It's really light. The very, very top line up here, we're starting with 0.5 milligrams of buprenorphine or something in that range. Very, very tiny doses. That's a quarter of the smaller dose of the smaller size strip. And we're doing that kind of as a test dose. And then increasing it gradually. Again, this is over 7 days. We have versions of this in our Epic Smart Set that are as quick as 3 days, you could stretch it out for weeks if you wanted to, if you have that much time, but it's a little bit arbitrary as far as the time. Other institutions, basically there are as many protocols as there are institutions that are doing this, I would say. Other institutions use transdermal buprenorphine patches. Those have very, very low doses of buprenorphine. You can use those for an initial starting dose. I've heard of institutions using very, very small doses of IV buprenorphine. People sometimes use the buccal film, which is a film that's approved for pain indications and is also a very, very low dose. So there's lots of versions of how to do this, but I think the principles are that you're overlapping that buprenorphine and layering it on top of full agonists. All right, so that's buprenorphine. The other thing I want to talk about for folks in the inpatient setting, before I move on, I will also say that this is kind of complicated, and that's why I would argue it's best to be done in a hospital setting where there's nurses that have orders and are looking through and giving the doses at the right time. You have access to lots of adjunctive medications if people are having some withdrawal symptoms. We're going to talk about the outpatient setting later. There's nothing wrong with doing this in the outpatient setting, but I think it's much more challenging for many folks to do that, and that's why I really highlighted it here for inpatient setting. The other things I was going to say about this were that at Harborview, there haven't been many studies of this as far as how effective it is, but there have been at least a couple larger cohort studies with a couple hundred patients, and it seems like greater than 80% of the time it's effective. People are able to make it all the way through this protocol without having to discontinue it due to withdrawal symptoms. So, I think it's a very helpful tool and strategy for hospitalized patients. I want to talk about methadone. Methadone has become more and more important, I think, as we've seen with the potency and degree of physiologic dependence for folks. Methadone is important. Methadone, for some historical context, we typically have titrated methadone starting at doses of 10 or 20, maybe 30 milligrams of methadone as an initial dose. You can give another 5 or 10 milligrams, and then every few days kind of going up by 5 or 10 milligrams of methadone. The challenge with that is that oftentimes that's not enough for people with that degree of physiologic dependence. And what happens is that people leave the hospital and don't get the necessary medical or surgical or psychiatric care that they need. And so really there's a movement now to try to be more aggressive with titrating methadone, higher doses, doing it more quickly. The study that's cited here from a few months ago was a pilot study at OHSU that just included, it was pretty small, 25 hospitalized patients. I'm following the speakers that talked about cardiology and endocrinology studies where there's thousands of patients. We don't have those. But there's a pilot study at OHSU with 25 hospitalized patients. They were admitted for the reasons that we often see folks admitted for: trauma, infections, some people with obstetric indications. Most of these people, 24 of the 25, had short-acting opioids being ordered at the same time. And they tried to use this more aggressive titration of methadone. This is a little bit misleading. The protocol allowed up to 60 milligrams of methadone on day 1, up to 70, up to 80, and up to 100 for days 4 through 7. But the actual ordering was something like 40 to 50 plus 10 if needed, and then again 60 plus 10 if needed. Most people got close to the full amount, though. There were multiple exclusion criteria. They were trying to really choose a select group of people where they thought this would be safe. So these are all folks who had dependence to fentanyl or other highly potent synthetic opioids. They excluded anyone with end organ failure, kidney, liver, heart failure, people with arrhythmia, concurrent benzodiazepine or alcohol use, anyone over 65, and anyone with methadone use within 7 days of admission. But among this select group, there were no adverse events, including things like holding a dose of scheduled methadone, having to administer naloxone, or transferring someone to a higher level of care. So I think there's a lot of interest in this. Our clinical practice at Harborview has really changed over the last year to be much more aggressive, and we essentially do something similar to this with folks who come in using fentanyl regularly. And similar to the pilot study, our clinical experience is that very, very few patients are having adverse effects with this. I think it's yet to be determined if it's enough to help keep people on the hospital. I think we unfortunately still see far too many patient-directed discharges. But I think we should be thinking about something more aggressive around our methadone management in the hospital. All right, my last take-home point for the inpatient setting is please, 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 it's a plea to continue medications for opioid use disorder for our patients throughout their hospitalization whenever possible. This was a cohort study or observational study in JGIM that was published earlier this year, just speaking to how disruptive hospitalization is to people's medication treatment for their opioid use disorder. It's a study at the VA, had over 800 veterans who were treated with buprenorphine. Most were treated for opioid use disorder, some were treated for pain, who were hospitalized from 2018 to 2020. Fewer than half the patients, only 44%, received buprenorphine at any point during their hospitalization. Patients treated with full opioid agonists were significantly less likely to receive buprenorphine. So you can see here 18% versus 46% among people who were not treated with short-acting opioids or full opioid agonists. And then most concerningly, over a quarter of patients did not receive a prescription for buprenorphine in the 60 days after their hospital discharge. So Society of Hospital Medicine recommends, these are guidelines from a couple years ago, recommends against interrupting treatment whenever possible. I'm just going to read this because they said it better than I probably could. Society of Hospital Medicine recommends that hospitals continue buprenorphine or methadone during hospitalization, including in the setting of acute pain and the perioperative period. Discontinuation of methadone or buprenorphine is not recommended during acute pain or in the perioperative setting and will result in an opioid debt, which may worsen acute pain, making treatment more difficult, and may increase risk of return to opioid use and opioid overdose. So remember that it's okay to treat patients who have acute pain and are on buprenorphine or methadone with short-acting opioids as appropriate for their situation, keeping in mind their higher opioid tolerance. I think some well-meaning people sometimes reduce the dose of buprenorphine or discontinue buprenorphine, but that in order to try to provide better pain control. I can pretty much guarantee you that no one in this room, including myself, is willing to prescribe as much short-acting opioid as would be necessary to meet that opioid debt from buprenorphine or methadone and address the acute pain issue. And really, it risks destabilizing someone's OUD treatment. And this is among folks that were already experiencing extra stressors because they're in the hospital for some reason. It's like a very stressful thing for anyone, of course. All right, I'll get off my soapbox around that. And let's transition now from the inpatient setting to the outpatient setting. So another case to get us kind of shifted into the mindset of being in the clinic. So you're seeing a patient in the clinic for depression. They smoke fentanyl multiple times per day, similar to our other patient. They've tried to stop using before, but they really cannot tolerate the withdrawal symptoms that develop. So this is that challenging issue where that fentanyl is sticking around for a long period of time. There's kind of a depot of it in the body. How are you going to recommend they start buprenorphine? I already alluded to the fact that trying to do that complicated low-dose start, you could try it. There's nothing wrong with it per se, but my experience has been that even in folks that are quite organized, it's a challenging thing to try to navigate. So really, I want to essentially talk about the opposite strategy, the withdrawal first, buprenorphine start. And really, it's going to be hard for folks to wait that days to weeks kind of time frame. And so what more and more folks are doing is moving towards high dose. Again, I don't really like that terminology because the dose is a little bit arbitrary, but we are going to ask folks to wait for a period of withdrawal. And then when they're ready to start the medicine, the idea is just to be more aggressive than we historically have been with dosing the buprenorphine. Historically, if anyone took like the X-waiver training a number of years ago, they would say start with 2 to 4 milligrams of buprenorphine once somebody has some withdrawal symptoms starting. Really, in the era of fentanyl, that is not really acceptable anymore. And really what we think it does is actually hit that sweet spot where you're displacing the full opioid, but not really providing a lot of agonism effect at the receptor. So people feel like worse than if you gave them teeny amounts and worse than if you gave them more. So the idea is let's give them a lot. Most of the data from this is from the ER setting because they do a lot of this, and that's the paper that I cited here. The other nice reference that's at the bottom here is Scala Northwest, which is a new organization in Washington that's providing a lot of kind of clinical protocols, patient education, et cetera, around addiction treatment. And so that's where this little diagram came from, which essentially speaks to how you're waiting for moderate withdrawal, and ideally you would have somebody wait for until they have like 1 or 2 objective signs of withdrawal, but it's going to depend on the individual what those are. But when that happens, take 16, some people say 8 to 16, but basically take 1 or 2 strips of buprenorphine, a sizable dose, wait an hour or so, and then if you're still having withdrawal, take another 1 to 2 strips, and you can do that up to 4 strips or 32 milligrams a day. Some people will say even more. We don't really know if more will be helpful or not. And then maintain people on 3 a day or 8 milligrams 3 times a day until follow-up visit. So it's a much more, I guess, aggressive start than we historically have done, and will be associated with some withdrawal, but the idea is hopefully we're providing as much agonist effect as we can during that period. Also okay, really for both the buprenorphine start strategies, the overlapping or the withdrawal first, fine to provide adjunctive medications, and I usually have a conversation with my patients about either what symptoms they typically experience or which ones they are most fearful of, and that's where I'm targeting my adjunctive meds so that they don't leave with a whole bucket of all 8 or 10 meds, but they have a couple things that they can reach for if they're more worried about anxiety, if they're more worried about nausea, et cetera. All right, the outpatient setting, this is pretty new, all the long-acting injectable products. So I want to spend a little bit of time on this. There's really now 2 formulations of long-acting injectable buprenorphine that are available on the market. The brand name of one is Sublocade, that's been on the market probably for maybe 8 years now. But just in the last year or 2, Brixadi is the other product that's become on the market. And the nice thing about this is that we now have both weekly and monthly formulations, and we have multiple dosing levels for each of those options. The other great thing about being in Washington State is that even the healthcare authorities decided to cover both these products for patients on Medicaid without prior authorization. So we really have pretty easy access to these medications. There are some additional regulatory requirements. Most of that is actually on the pharmacy side. So there's a risk evaluation mitigation strategy plan or a REMS plan that the pharmacy has to implement. Providers really can only obtain these products from certain specialty pharmacies. The DEA's main concern around this is wanting to get the products directly to a provider and not directly to a patient. So the main concern with all the REMS plan and everything is like they don't want the patients picking this up. This is something that should be administered by a provider in a clinical setting. The FDA dosing guidelines for these are what I wanted to mostly focus on. They really talk about how people should be kind of stable on sublingual buprenorphine before starting some of these products. And really the emerging evidence is that's probably not necessary. And so I want to highlight actually a couple studies about that. The first is this study from Drug and Alcohol Dependence earlier this year that was a pretty large claims-based study in Canada. They enrolled 3,000 or looked at 3,000 patients on Sublocade. There's more of the studies are on Sublocade because it's just been around longer in Ontario. So in this study, they found that patients basically had some days of sublingual buprenorphine. 4 to 7 days was the range, which is less than the manufacturer recommends, which is at least 7 days, and that people did fine with that amount. They also found that most of the patients in this cohort needed supplemental sublingual buprenorphine. I think sometimes providers feel uncomfortable when using the LAI and also prescribing sublingual buprenorphine on top of it, but most of the majority of patients, a slight majority, needed that in order to stabilize their symptoms. So that should, I think, be considered completely acceptable clinical practice. And then almost half the patients needed higher doses of the injectable for a longer duration. So again, the manufacturer recommendation for Sublocade, for example, is to give 1 or 2 months at the higher 300 milligram dose and then go down to the monthly 100 milligram dose as the maintenance dose. We are finding, again, especially in the era of fentanyl, that that's insufficient for most people, and really almost all of our patients that are using fentanyl are continuing on the higher 300 milligram dose, which is the case for almost half the patients in this big cohort or claims-based study in Canada. So I think that should be considered a totally acceptable practice. This is just another study pointing to the fact that it's probably okay to give less of a run-in with sublingual buprenorphine before starting somebody on a long-acting injectable. This is a cool study from JAMA Network Open earlier this year that was performed in the emergency room, including at Harborview as one of the sites. It was a non-randomized study, 100 patients who got the 28 milligram or the highest dose of the weekly Brixadi injection. And they essentially checked their COWS scores and stratified people by their baseline COWS score. COWS is the clinical opioid withdrawal score. So either 4 to 7, meaning they had mild opioid withdrawal symptoms when they got their injection, or 0 to 3, meaning which they had no opioid withdrawal symptoms when they had their injection. And then look and watch them for 4 hours. Did anybody have precipitated withdrawal? And really, when people had mild withdrawal symptoms, only 3% of people had precipitated withdrawal within 4 hours. And even in the people that had 0 to 3, like no baseline opioid withdrawal, it was still relatively rare. Less than 15% of people had precipitated withdrawal within 4 hours. That precipitated withdrawal was defined as a 5 or more point increase in their COWS score during that 4-hour period. They went even further and they actually stratified people by mild or no withdrawal, fentanyl in their urine test, or no fentanyl in their urine test. And you can see here that really the issue is people who have no withdrawal and have fentanyl in their urine test. That's where you get almost 20%, 18% of people had precipitated withdrawal within 5 hours. So that's the highest risk group. Still, the vast majority were not having precipitated withdrawal, even in that group. In the other groups, the rates were very low, essentially 0 in people that weren't using fentanyl, and very low in people that were using fentanyl. So I think the take-home point here is that we should probably be more aggressive with our long-acting injectables. We probably don't need to be giving people lots of sublingual buprenorphine before starting them, and that they are a very helpful tool, not only for people, I will say, not only for people that have adherence difficulties. I think we think about LAIs when folks are having adherence challenges, which is a totally valid reason to give them. But I've also had many patients that that talk about how it's very helpful to be avoiding the reinforcing effect of like reaching for a sublingual something to take every day or multiple times a day. Really, they come in, they get their injection, and they go about the rest of their lives for the month until they're due for their next injection. And I guess, not to just be up on, talk about this over and over, the other nice thing about the injectables is that you can get higher doses, higher serum levels of buprenorphine with the injectable products than you can with the sublingual formulation. We think, I don't know how much weight to put in these. They do these kind of PK studies. They draw people's serum levels at peak and trough and all this stuff. Probably on average, people's serum buprenorphine levels are 2 to 3 times higher with the injectables, especially the higher doses of the injectables compared to sublingual buprenorphine. All right, we finally made it, and folks are still hopefully mostly awake. Regulatory changes. Let's do a quick case here. You see a patient with opioid use disorder who's interested in treatment. They are not interested in buprenorphine. They've tried this several times recently. You try to kind of explore that and unpack that with them, but they really are not wanting to do that. They're maybe a little more interested in methadone, but they really don't want to have to go to clinic every day. They have a lot going on in their life. It's just as intimidating to have to go dose every day. So how are you going to counsel this patient about methadone treatment? We're going to talk a lot about methadone treatment and how it's changed recently. First, though, I just want to make sure everyone is aware that the X waiver is no longer needed. This is old news, essentially, now. It was eliminated in in January of 2023, so almost 2 years ago now. There are no longer any limits on how many patients you can treat. As long as you have a DEA license to prescribe a controlled substance, you can treat people with buprenorphine. There is a one-time 8-hour substance use disorder training requirement when obtaining or renewing your DEA registration. I'm assuming we're almost through to the point where everyone has done that, because I think DEA licenses generally are renewed every 2 or 3 years. So that's an important thing to do. That's a one-time requirement, so you won't have to do that with subsequent renewals unless the law changes. The only other caveat with this is that relaxation of training requirements don't necessarily translate into more buprenorphine prescribing. So this is another JAMA Network Open study that was published this year, which was actually focusing not on the removal of the X waiver, but before the removal of the X waiver, they removed the requirement to do 8 hours of training. So you still needed to get an X waiver, but you didn't have to go through the 8 hours. You just had to tell the DEA that you were going to do this and then get the X number. So they looked at these 4 jurisdictions: New York, Kentucky, Massachusetts, and Ohio, places where there was a lot of high opioid overdose rates. And they looked basically on the left-hand side. This is number of X-waivered clinicians. That went up everywhere when people didn't have to go through the 8-hour training. But the number of buprenorphine prescriptions over on the right-hand side, it was essentially flat everywhere. So more people X-waiver didn't translate to more buprenorphine prescriptions, which is not at all surprising, because even before that, we had studied people that went through the 8-hour training, and very few of those people end up prescribing buprenorphine or prescribed to very few people. So I'm a pro getting rid of the X waiver, that's great. It's the only thing to be cautious of is thinking that it's solved the problem. More work to be done on this, of course. All right, telehealth flexibilities. So during the COVID pandemic, the height of it, I will say, there were a lot of telehealth flexibilities that were introduced. So specific to buprenorphine, folks that have a DEA registration were able to prescribe controlled substances via audiovisual, and for buprenorphine specifically, via telephone only, like audio only visits. Those flexibilities have been extended and extended and extended and are now set to expire December 31st of 2024, so next month. There are draft rules out that would extend those another year or 2, and so we're waiting to see whether or not those will be actually approved. Really, it's going to take a congressional fix, a congressional action to kind of permanently fix these or change these rules. So just keep an eye. I think this is a plug to kind of keep an eye out about what happens with these telehealth flexibilities in the coming weeks and months. All right, finally, last point here, not your same old methadone treatment. So this is a major update. So methadone guidelines or regulations hadn't been updated for 20 or 30 years until February of this year, when 42 CFR Part 8 revision went into place. There are many, many, many provisions within this, and I'm only going to highlight a few that I think are particularly applicable to generalists. But One of them is it expands treatment eligibility. Previously, people could only be enrolled at an opioid treatment program or methadone clinic if they had at least 1 year of opioid use disorder diagnosis, which is kind of wild because people can meet the criteria much sooner than that. That 1 year minimum duration of the diagnosis is no longer the case. It also expands the criteria not only to people with a moderate to severe opioid use disorder, but also people with opioid use disorder in remission. So if there's a reason that they're at risk for going back to use, they're eligible for methadone, they weren't before. Also, people at risk of recurrence or overdose are also eligible now. We talked about the dosing, like being more aggressive in the inpatient setting. The DEA is allowing a little more flexibility in the OTP setting, still not as much as we probably need. Previously, the regulations were that you could not get more than 30 milligrams on the initial day of methadone treatment at an opioid treatment program. Now the initial dose has been increased to 50 milligrams on day 1, so that's better for people. I think it makes sense that in a non-monitored setting, they can't be as aggressive as we probably should be in the hospital setting where we have eyes on 24/7. But I think it's a move in the right direction here. The regulations also allow split dosing now. Before, only people who are pregnant were allowed to have split dosing, like come and get their methadone morning and afternoon, for example. Now people, in addition to people who are pregnant, people who are known to be high metabolizers, which is a very small fraction of people, but an important group. Also people who are taking medications that induce rapid metabolism of methadone, which is there's the slate of CYP 3,4, of inducers that increase metabolism, and then individuals with chronic pain, which is a huge thing because so many people with opioid use disorder have chronic pain. And then lastly, and most importantly, there's more flexibility around take-home doses earlier in treatment, which is getting back to the case that we were talking about. So historically, which is the middle column here, you had to be in treatment for 90 days before you were able to get your second take-home dose. So everyone that starts treatment comes into the clinic Monday through Saturday, and then everyone gets a Sunday take-home dose. And then it would take 90 days in treatment with appropriate urines, no missed doses, all appointments kept. Then you would get a Saturday and Sunday take-home dose. At the 180-day mark, so 6 months into treatment, you'd only have to go 4 days a week, and then 9 months into treatment, you could come once a week. Now, with the new regulations, there is more flexibility at the discretion of the medical provider or the OTP medical director. You can go straight to once a week dosing with methadone, and then within 15 days in treatment, you could do 2 weeks, and after a month, you could do monthly take-homes. So not everyone is able to do this right away, and I think that the biggest challenge around this is that there's now much more variability between opioid treatment programs as far as how much flexibility there is in the dosing. There are OTPs locally that do this new kind of schema much more quickly, and others that are much more aligned with the previous kind of length of time and treatment requirements. There are, I think there are the DEA recommends a set of criteria around like risk of overdose and regularity of attendance, and a whole set of things that prescribers are supposed to continue. But I think just it's an opportunity to remind patients that methadone treatment isn't what it used to be, and it might be something to reconsider if this is the biggest issue that's keeping somebody from doing it. And it's interesting that coming out of the pandemic, early studies, there have been several studies actually showing that the rates of methadone-related overdose deaths were really not changing much with the new flexibility around how many take-home doses people were getting. And even one cohort study demonstrating that there's improved treatment retention with that kind of flexibility. All right, so I'm at the end of time and the end of the talk. The recap, though, is that fentanyl has been a game changer for hospitalized patients. Think about an overlapping strategy for starting buprenorphine. Think about titrating methadone more quickly in carefully selected patients, and please do not interrupt medications for opioid use disorder whenever possible. For outpatients, think about using higher starting doses of buprenorphine in patients with high tolerance. And long-acting injectable buprenorphine is a good option for lots of patients and probably easier to start than we think. And then the regulations are rapidly shifting. No more X waiver to deal with. keep an eye out on telehealth flexibilities, and methadone treatment is not the same old methadone treatment. That's all I have for you.